Don't know the answer.
All right. So,
All right.
Dr. Farooqi, do you have your case ready?
Yes, sir. I just need 2 minutes to upload it.
Sure, feel free. I'm just going to introduce yourself in the meeting, and we'll just wait for you to share the screen. So, everyone, hi. Good evening, good morning. So, this is another one of the International Trauma Telegram rounds. Today, we'll have the honor of having Dr. Farooqi as a presenter. She is Associate Program Director of Surgical Critical Care Fellowship in Trauma, Emergency General Surgery, and SCC faculty. She's working in Staten Island University Hospital, Northwell Health. So Dr. Farooqi was a presenter previously here. She had a beautiful case. So we are thrilled to have her presenting another case, and hopefully we'll have you presenting lots and lots and lots more cases along the weeks. All right. So I see that we have a lot of people joining. So I'm thinking that I'm thinking that we will have a lot of participants and people to discuss. I'm sure Dr. Untrak, Dr. Kasim will be available to as panelists, and also Dr. Varun is here. I saw a lot of people. Dr. Collet is also here. So just feel free to start whenever you're ready, Dr. Farooqi, and we will make some stops along the way. If you don't have the stops already prepared, we can just stop in strategic points of the case to have the discussion. Thank you
So
very much.
I do have some questions. So it's going to be like last time. The slides we'll discuss the case in the middle before first of all, can everyone see the presentation and the slideshow?
Yes.
And then it will be a more of an interactive session, and I just want to thank everyone for giving me this opportunity again, and we'll be learning a lot for sure. Okay, so this is a case of a 75-year-old. Oh my God, sorry, this is a boo-boo. I think I uploaded the wrong presentation. Give me 1 second.
No worries.
Oh, yeah. Am I still sharing or am I not sharing?
No, you're not sharing anymore.
Okay, let me share again. Okay. All right, now I'm sharing. So we have an 18-year-old male here who presented to our ER after a stab injury. He was brought in by the EMS, and he was intubated with a King's tube on the field. On presentation, the EMS didn't have much to say. They just said, we found this guy. He was like, kind of like he was not really responsive that well. Like he was talking, but not that much. So as a precautionary measure, they put a King tube. On primary survey, he had a King tube in place, and then he had bilateral breath sounds were heard, but the right one was lesser than, continue to share. Right was lesser than the left, so we placed a chest tube in. At that point, he was like, the pressures were soft. He had like 400 cc immediate return, sanguineous. So MTB was activated. We repeated the survey, and at this time, we exchanged the LME for an ETT tube with glidoscope. He was normotensive after that. His heart rate was like late 90s, and he was found to have a thoracoabdominal stab wound in this area on the right side. Is everyone able to see my cursor? Great. So it was the wound was here. FAST was performed quickly in the ER. It was positive in the right upper quadrant, and there was mild pericardial fluid. So at this point, we decided to take the patient to the OR. My question would be, what surgical intervention would we be thinking about this patient appropriate? Just like, looking at the presentation, looking at the imaging, looking at, the whole picture. What would you be thinking about in the OR? What would you ask the OR staff to open?
Perfect. Dr. Untrak, can we start with you?
Certainly. So go to the OR, and totally biased by the title and the flyer, and I hope I would say the same thing if the patient didn't come with the flyer, on top. But I would make a upper midline incision up to the xiphisternum and immediately pack the abdomen. If he's exsanguinating from the abdomen and the blood pressure goes down, you have to deal with that first. But if not, if he remains stable, then I would start with a subxiphoid pericardial window, and he'd be prepped for trauma from chin to the knees, frog leg, being prepared to do what you need to do. Now, it's always, you can always sound like a genius if you know the answer ahead of time, but I hope I would say the same, do the same thing with a patient coming to me directly.
All right. What about you, Dr. Kasim? And can I ask you a question? Would you explore this wound in the ED?
I will answer you in a minute, but before that, I will answer Dr. Farooqi. She said, what would you be thinking of? So I'll be thinking of 2H and 2Ts. 2H meaning, is he hypoxic? Is he hypotensive? Is he got tension? Or is he got pericardial effusion with tamponade? T, 2Ts. So you said that he has fluid around the pericardial fluid. That tells me that he's got 1T at least, which is pericardial fluid indicating cardiac tamponade. Now, would it be significant for me to know that? And with that kind of injury that you have described, yes, it would be very significant. I would add 1 + 1 is 2. I have a stab wound in the box. And by the way, that box that you're showing is called the Ziegler line, which is because it is expanding more than the nipple. And so I would be extremely suspicious that he's got cardiac injury. And therefore, that is where I would put my money. And I would immediately take him to the operating room. And either I will do as subxiphoid incision, like Dr. Untrak says, more than likely I wouldn't even do that. I think I would follow my acumen and I would do a thoracotomy because I'm suspicious this patient has a cardiac injury and I need to deal with it. Thank you.
Great. That's excellent. I don't know if Dr. Luis Taveras is already ready to jump in. Dr. Luis Taveras, if I'm not mistaken, he works at Duke University. So Dr. Taveras is there. So Kevin, can you enable Dr. Taveras a microphone and video, please? So he can jump in the discussion as well.
Yes.
And also Dr. Hodgman is here.
Oh,
Dr.
perfect.
Hodgman, I saw his name.
Hey, Dr. Hoffman, how are you? If you want to jump in, just let me know.
Yeah, they both have access now. Hi,
Great.
who's here?
Thank you, Kevin.
Can you hear me?
Sure, happy to be part of this. Thank you.
Yeah. So, Dr. Taveras, what are your thoughts on this?
You know, someone in the chat wrote a question that I think brings some interesting points. I'm gonna start by saying that I would probably approach this the same way as Dr. Ontrek has described. I think that's very basic way of looking at this, right? You have a thoracoabdominal wound, you go in, do your laparotomy, pack, make sure anesthesia has enough time to kind of catch up and do your pericardial window through your abdominal incision. And if you need to extend and do a sternotomy, Jaime Villacuran asked about minimally invasive approaches, right? And doing a thoracoscopy. You know, based on the experience that I've heard from other people, especially in Latin America, I think this is a very reasonable option. Not in my hands. I work in North Texas, so my rates of penetrating box injuries are lower. So I'm concerned that my time to do a sternotomy is not as fast as I'm not gonna waste time doing a thoracoscopy and then having to crash to do a sternotomy. But I think in the right hands, this might be an option. And I think it's worth discussing and see if any of the other panelists have had experience with um, minimally invasive approaches to the evaluation of pericardial effusions.
Great comments. Thank you. Before we move to Dr. Hochman, Dr. Farooqi, were you able to see, you mentioned that you had a right chest tube putting out some hemothorax, is that correct?
Yep. So it was 400 cc that came
Perfect.
out. And then it was not pouring, it just stopped after that. And then we did a fast, but the fast was not, we couldn't see any tamponade. We suspected that there could be, an injury all the way, but it was not tamponade. So, and the patient had vital signs and he was not dangerously hypotensive or tachycardic. So we decided to take the patient to the OR. The initial plan was to do an XLAB pack and then, also give a pericardial window, see what we can find there. If there's, but then obviously the next the next step would be to call CT and, already start with our median sternotomy.
Yeah, so let me just ask a question for Dr. Hochman then. Dr. Hochman, so now that you have a positive EFAST, I mean, a positive chest tube on the right, a positive EFAST on the right upper quadrant, and also a pericardial effusion, how can you, what can you tell us about what cavity should you address first? Maybe the thorax, maybe the abdomen, as Dr. Farooqi said. So they opted to go to the abdomen. But what are your thoughts? How can we decide upon this in the next case, for example?
So I will go, the thing that I will be more, that worries me is what is going to kill the patient first. If the patient has a cardiac injury, that's most likely to kill the patient first. So that's where I will go first. Can he has an intra-abdominal injury? Yes, it's possible, but the stab wound, you are draining blood through the chest. That could be from a hole in the diaphragm and bleeding from the abdomen into the chest, and I have seen that happening. But the patient is hemodynamically stable, so doesn't appear to have a major bleed. So the bleeding appears to have stopped after the chest tube. So you don't need too much fluid in the pericardium to cause a pericardial tamponade. 200 mLs usually is enough to essentially cause a significant pericardial tamponade. Meanwhile, 200 mLs in the abdomen is not a big deal. So I will go to whatever is the most serious potential injury. And for me, the most serious potential injury is the pericardium. I prefer, if I have the chance, and I agree with Dr. Undrak, I would prep this patient from the neck to below the groins, the arms on the side, not extended, which anesthesia will complain. But you need to have the arms on the sides if you need to do median sternotomy. And I will start with a subxiphoid window without entering in the peritoneum. And the reason for this is that is unlikely based on the location that the colon might be injured, but it's possible that might have been injured. So I don't like to contaminate the chest with bowel contents if I can avoid that. Having said that, there are cases that you have no option. But I will do the subxiphoid window. If the subxiphoid window is positive, I will convert to a median sternotomy. A significant number of the pericardial penetration, the hole in the pericardium tend to seal and the patient develop pericardial tamponade, but there is another number of patients that will bleed into the pleural cavity. So he could be bleeding in the pleural cavity from the lung, from the pericardium, from the heart, or from the abdomen. Those are the three possibilities. The one that worries me the most is the heart. So I will go there. If the pericardial fluid is bloody, I will proceed with a median sternotomy and go from there. If the patient remains stable after whatever I have to do in the chest, I will close the chest before entering the abdomen. That will be my preferred approach. Having said that, I have patients that they were open like they have an autopsy all the way from the neck to the pubis because they are bleeding in multiple places at the same time, but doesn't appear to be the case. Regarding the question in the chat about going through a right thoracotomy, I always kind of say half joking, but it's half true. If there is something that can be a mistake or something that can be done wrong, I've probably done it at least twice. So I have done that. It gives you really a very poor approach because you don't know where you are bleeding from. If it's bleeding from the abdomen, you have a thoracotomy and the bleeding is coming from the liver. And to access the pericardium, you end up doing you will not be able to do anything from that side. You will end up doing a clamshell incision, and the morbidity of the clamshell incision is significant. So I would not do that. The same way that in a case like this, I would not do laparoscopy or thoracoscopy because the patient can decompensate very quickly with a pericardial tamponade. So those, for me, are not an option. But I understand that some people might prefer to do that. And that's all I have. Thank you.
Perfect. Thank you, Dr. Hoffman. Dr. Varon, you have your hand raised. Please feel free.
Yes, I have a question for Dr. Farooqi. It's just from when the patient arrived. If the patient had you said he had the airway is what I didn't understand. Why you went from a laryngeal tube and then to an LMA and then to intubation. Well, I mean, if you're going to change a laryngeal tube, then usually intubate at that point rather than using an LMA. Was there an issue with airway there?
The patient, so it is just part of our policy. If an airway is, if a patient comes in with an airway from outside in any case, which is they usually are not intubated. So once while we are doing our primary survey, we quickly change it.
Yeah, but no, I understand you change it, but makes no sense to change the airway that you discussed, the king airway, which is a supraglottic, for another supraglottic, and then intubate. You said that initially the patient had a king airway, not an LMA. Then you went to an LMA, which makes no sense, and then to intubation. That is why I didn't understand that unless they had some issue.
I think it could be me writing it wrong. Yeah, but the patient's airway was just once. It could be an error on my
Okay.
side.
The other thing, what was a Glasgow Coma score on arrival?
On arrival, he was moving his he was not following commands. He was just moving his extremities.
Okay.
But
Was there a need to intubate at that point? The reason I'm asking is from the vital signs you're giving, at that point in time, the patient was not in tamponade, correct? He could have pericardial fluid, but you said normotensive, the heart rate is in 90s. You don't see that in tamponade. Now, if you intubate it and then you saw hypotension and all that, definitely the patient is in tamponade. And normally these patients should not, intubation and positive pressure in a patient having a tamponade, it's not good. And those patients should be addressed in the operating room because as soon as you intubate them, do positive pressure ventilation, they're not going to do well, and then you'll have to emergently drain. So I don't know what happened after the intubation, if the patient deteriorated or not. Because right now, with the vital signs you're giving, the patient is not in tamponade, there's no JBD, normotensive heart rate. That doesn't mean he's not going to develop it, or that does not mean he's going to crash after intubation. That's number one. Number two, I think in our place, I'm not a surgeon, but what we would do is, as I mentioned before, the first is to address if the patient has a tamponade or not, and to do a pericardial window. That would be the first thing. And then just to confirm the diagnosis. That will be diagnostic and therapeutic, right? You have tamponade, that will release it, and you'll make the diagnosis, and then you can do a thoracotomy at that point. The only thing I disagree is this thing about keeping the arms under everything. Think about this, guys. When you do a neck to pubis prep, okay, and you want the arms in, the anesthesiologist can only monitor the baldness of the patient. There's no margin, there's nothing. We can't give fluids. You can do whatever you want, but we can't do anything. So I disagree with keeping the arms on the side. We need some access to be able to resuscitate the patient. Not only that, the room is going to be hot because you can't put a bird hugger. You guys are going to suffer with that temperature that we're going to crank it up to maintain normal thermia, because you can do the operation and they have a patient severely hypothermic and coagulopathic, and that's not good as well. So let's see what happened next.
Perfect. So I see that Dr. Collet and Dr. Hoffman have their hands raised. So Dr. Collet, you can open your mic, and Dr. Hoffman, then you can do like a quick comment before we move on with Dr. Farooqi.
Okay, I think there is some problems can see here. I want to know how was the lips of the wound, because some stab wounds can be upper or down to abdomen, and maybe there is sometimes can suspect injuries. If the injuries can see the lips of the injuries, you can try to think the injuries going from down to up, for the abdomen to chest, or for the chest to abdomen. There is difference on what's happened and what to think about first. Then you have fluid in the pericardium, fluid in the chest, and fluid in the abdomen. So there is a great problem. The patient is hemodynamically stable, although we have all the procedures you use for the intubation, there are problems. So you can maybe fluid in the pericardium, maybe problem of the late of the patient, or maybe probably in this situation, maybe blood. Sometimes when you see the blood in the pericardium, it's not, sometimes you can see in the Colombia reports that can be fluid in pericardium. Stable patient, you can make a pericardial window, can see, if you had seen the blood, you can wash the pericardium and put a drain if there is no activity in bleeding, and observe. So you needn't go to a sternotomy. Usually I go to a sternotomy or a thoracotomy because my experience here is not very bigger than the Colombia that was using this kind of the treatment. And I believe if the patient can be stable, can go to a sternotomy, can treat the heart injuries or not, can see the pericardium, you can see the diaphragm in this area, and then you can know if you can go to a laparotomy, or sometimes you can put a laparoscopy and see the abdominal cavity. I think it's very important you can go to see the abdomen in this situation by laparoscopy or by laparotomy. But the pericardium, you can see first, go to a pericardial window, wash if the patient continues stable, and sometimes you can put a drain and observe. And then you needn't to go to open the sternotomy or the anterolateral thoracotomy in these situations. So there is a problem because sometimes you have discussion with the Colombian, and then Hans says that sometimes in pericardium, stable patients with fluid in pericardium, you can wait and can be only a conservative management.
All right, perfect. Thanks a lot. Dr. Hoffman, quick comment, and then we move forward.
No, I just want to clarify for Dr. Baron that I would never prevent anesthesia to putting lines in the arms, but they do that when the moment the patient gets to the room. If the patient is not in extremis, like in this case, we will prep the patient before starting the anesthesia procedure, because as Dr. Baron pointed out, he might develop pericardial tamponade by the time you go there. And the moment that you do the induction is when they crash, and you need to be ready to open the chest. So they will have lines on the arm, they will have the either arterial line or the cuff on the arms. And after that, we tuck the arms, we prep the patient, and that's when the anesthesia will be induced. We have cases that we have placed groin in the middle of the case. We have the groin is prepped. We will put an additional line in the groin to give volume if necessary. But I would never prevent anesthesia for having lines in place. And also you have the neck too. So just I want to clarify that that's the case. Thank you.
That's perfect. Thank you very much, Dr. Hoffman. Dr. Farooqi, I think we can move on.
All right. So prior to the transfer to OR, the patient became hypotensive to 60s and tachycardic to 130s. We checked the right chest tube, no blood was pouring out, and a repeat fast was performed. Pericardial tamponade was seen, and there was complete collapse of the right ventricle. And also, while we were doing this, the patient lost the pulses. So what should be our next step then in the trauma bay?
All right, Dr. Kassim, suddenly the patient arrests.
I expected I expected that. That's the reason why, right from the beginning, I said my focus will be on to prevent the T, which is tension, which is cardiac tamponade, period. And so I'm not surprised the patient arrested right in front of your eye. So the next thing would be I would tell my trusted anesthesiologist, Dr. Verone, who knows what to do in cases like this, to pour in as much fluid as possible, because now what I'm seeing is probably the ventricles are empty.
Yeah, but
And
however,
I will ask him to.
I want to make a point though. If you have a hole in the heart, you really have to keep the blood pressure hole, because if I set up the Belmont at 5 liters, you're not gonna be able to fix the hole because it's gonna be bleeding out of the heart. You won't see the wound. So actually, in that circumstance,
that is
we would like to
true.
keep the pressure
But
low until you fix it.
You will be initiating it for me that we are working concomitantly. While you're doing that, I'm doing my thing too.
Correct.
So I would do a transverse clamp cell incision in a situation like this. I would not do either anterolateral or right thoracotomy or anything like that. Right across the chest, and I get a panoramic view of what's happening, and put my finger in the dike and wait for Dr. Verone to catch up with me. Thank you.
All right. Does any of the panelists have a different opinion aside from a clamshell thoracotomy? Just so we can get ahead of time here before.
The bottom line, you have to stop the bleed first. So you have to stick something in to stop the bleed, and then you can actually fill the tank.
Yeah, definitely.
I agree 100% with what Dr. Kasim said. You have no option but to do a thoracotomy in this case. No subcypher window or pericardial drain or anything. The only thing I will do in a case like this that maybe is a little bit unusual, I will close the hole. When I find the hole, I will close the holes with staples. And I will take the patient to the OR to complete the case in the OR and the control circumstance. I would not try to repair this in the emergency room, but that's me. Some of my partners do it in the emergency room. The other thing is that you don't have to, and this, you don't have to worry about anesthesia. The patient's in cardiac arrest. You open, when anesthesia gets ready and you start dealing with this, the moment you release the tamponade and the patient starts having pulse, is when they wake up. And that's when you need to have anesthesia. But this patient is unconscious. You don't wait for anesthesia. You just open the chest and relieve the tamponade. That's the main thing at this time.
Hopefully, anesthesia will be there with you, so you can do it at the same time.
Same, but I wouldn't wait for anesthesia to be ready and say, "Oh, now
you'll never have to wait for us. We'll be there."
One other thing, Dr. Menegoza. I think the best approach is not to go for the repair immediately. I think you just put your finger on the dike, if it is what you're seeing, and then wait for the anesthesia to catch up with you, to fill the tank up. And while they are doing that, you can get ready with your sutures and all that, or even staples if it is amenable to that. And those two, or a Foley catheter, whatever methodology that you're going to use to stop the bleed. And that's what I was advocating here. Thank you.
Yeah, perfect. So Dr. Hoffman told about the staples. Sometimes people just put the fingers or put some sutures, right? I don't know if any of the panelists have a different opinion in terms of what to do in this situation that the patient just arrested. But if you do have a different opinion, just raise your hand and we can address that. If not, I think we can move on, Dr. Farooqi, and see what you've done.
Yeah. Is my screen still sharing?
Yeah. Now it is.
Okay. So we proceeded with an ED, resuscitative thoracotomy. When we went in, we found that there was tense pericardium, and then we did a vertical incision, released around 200 cc of clot. At that point, there was return of cardiac activity. While we were in there, inspected the heart, there was no visible laceration that was seen or abrasion on the initial inspection. The hemidiaphragm was intact on the left side. There was no visible injury to great vessels. Lung parenchyma was intact. Patient's vitals were back at this point, and then we decided to transfer the patient immediately to the OR to do the abdominal part of this procedure. In the abdomen, once we went in, we found a large amount of hemoperitoneum. This was evacuated. Packed initial, we knew that there was, the liver, there was an injury there. We did a systemic packing, then, looked at the liver. There was a grade 3 laceration there, packed it again, put quick clot, checked the whole entire abdomen for any additional injuries, didn't find them, and then also performed a cattle brush maneuver. This diagram was more for, any residents or trainees here, but IVC aorta were fine. They were not injured. Then at this point, we decided to leave the patient abdomen open, resuscitate the patient because his base deficit was going up. He was becoming acidotic. And also we wanted the patient to be taken to the IR immediately, CT, and then get a CTA to see if there's any embolization that could be done from the IR. So Aptera a temporary abdominal closure device was left in place. CTA was performed, and it showed a large liver laceration, but there were no active extravasation that we could see. Similarly, yeah. So then the patient was taken back to the OR in 48 hours after resuscitation. Abdomen was re-explored. Packing was removed. The liver laceration at this point measured, we were, more relaxed environment at this point. So we looked at the liver laceration, was 10 centimeter. We also found that there was a right diaphragmatic injury was there. So some hemostasis was obtained by electrocautery, and the laceration was also packed with Surgicel mesh. And then the right diaphragmatic repair was performed in interrupted fashion, non-absorbable suture. Abdomen was closed, and the patient was returned to SICU. Post-op day 1, 18-year-old kid did really well. We extubated him. Post-op day 2, we performed an echo, had a reduced EF like 55 to 60%. We were expecting like a higher EF on him. RV was fine. No valvular pathology could appreciate. However, on exam, he had a friction rub, so we consulted cards. After looking at the history, they said just start on colchicine for 3 months, which initially it was like more of a discussion. Then we started it for the, to prevent any inflammatory response to the trauma. He was transferred out of SICU on post-op day 3, post-op day 8. We were looking at his LFTs. They were uptrending. The PCT showed a perihepatic collection. There was a concern for biloma. IR drainage was performed. It was actually return of bilious fluid. No growth. The cultures did not grow anything. Now, the point where the plot thickens is that on post-op day 12, the patient, he was doing fine. We were thinking of discharging him, and he had a syncopal episode. We performed a CTA, and it showed a large effusion adjacent to the right ventricle, which measured around 6.3 centimeter, and it was causing some compression on the ventricle as well. And they were also, at the same time, there was segmental, subsegmental PE in the branches of the left lower lobe of the pulmonary artery. So at this point, what would be your next step?
Wow, interesting. Dr. Taveras, what would you do? I don't know if, Kevin, can you check if Dr. Taveras has mic?
Yeah, he does. He's just muted right now.
Perfect. All right, let's see. Dr. Taveras, are you there? All right, so while we wait for Dr. Taveras, Dr. Kasim, what are your thoughts?
First thing I would pray. Second thing I would call the cardiac surgeon and get an opinion from him. And then I would kind of feel sad, in my own opinion, that I missed something here at the initial operation. I don't know whether I actually lifted their heart and had a good look at it in the back of it, because you cannot have a significant cardiac tamponade event and not find anything in the heart. That means that I was foolish and I missed it. And I would look for something that is in the back of the heart, and have my cardiac surgeon work with me to see if I can repair this off pump, or maybe I have to go with the help of the cardiac surgeon on pump and let him take over.
All right, Dr. Untracht, do you?
I would not be doing this anything by myself. I would definitely get help from the cardiac surgeon.
Yeah, definitely. Dr. Untracht.
Yeah,
anything?
yes, I agree, and that was my concern, hearing that after you did the anterolateral thoracotomy on the left, and you released this horrible tamponade. The patient woke up, went to the OR to explore the abdomen, but I think that part is fine, but and this was not with the benefit of advance notice or the flyer, but I was concerned that you didn't do a median sternotomy then to fully explore the heart. That was it. In retrospect, so I don't know who was there, if you were there, doctor, you had your fellows, if Dr. Farooqi was by, or the fellows were there, but I think that to learn from this case, but I would, because the blood didn't get there from outside in, or you have to assume that there was a primary injury that's there, and that was the best opportunity to pick it up and repair it before the emboli. At this point, I would call the cardiac surgeons, and they can, they might have to go on bypass, and they can try an embolectomy of those pulmonary emboli, depending on how large they are. But so the procedure is a little bit different at this point.
Yeah, great points. Dr. Hoffman, do you have any additional inputs?
No, I agree with Dr. Untracht and Dr. Kasim. This is beyond what we will do as trauma surgeons. I have dealt with similar cases like this, and you think, oh, it's a loculated diffusion. It's usually a very well organized clot, and you have no plans. And also, you don't know where the location of the wound is. So it's very difficult. It's very easy to try to go there, and suddenly you start removing organized clot, and you have no place to put sutures because you are not really on the muscle. So this has to be done either on bypass or with bypass ready to go on bypass, because suddenly you might have go through a median sternotomy and have a major bleeding that you cannot control because you cannot see. So this is one of the cases where I really will consult cardiac surgery. Regarding the initial surgery, I used to work with a guy who was senior to me, who used to say that through an anterolateral thoracotomy, you can repair 95% of the cardiac injuries. I never saw him do this, so I don't know if it was really true or not. I can tell you that I am probably a horrible surgeon because I could never do anything through an anterolateral thoracotomy, and 100% of my cases I converted to a clamshell incision, which gives you a wonderful view compared to the anterolateral thoracotomy. But maybe that's me. Maybe somebody can do it. But in a case like this, as Dr. Kasim said, you need to find the source. And so I will do an anterolateral thoracotomy and find the source. This patient has a hole somewhere. Dr. Collet, who I admire and mentioned that you can put a drain and see what happened. I am very reluctant to do that. And I'm very reluctant to do something like that because the quality of the paper that I have seen so far, maybe something was published recently and I'm unaware, is kind of lacking. And I think it's something very risky because I have seen many times, not once, many times, these cases that, oh, we can wait and see what happens, has a tiny effusion, and the patient is intubated and positive pressure ventilation. Suddenly they start coughing, they do Valsalva, and they start leaking and leaking and leaking and present a few days later with something like this. So the bleeding might initially be a stop in the operating room only to restart later on or have something like this case. So I wouldn't leave the OR until I find where the blood came from. And I will extend the incision and look for a hole in the heart.
Perfect. Dr. Collet, any comments?
Yes, I have one comment. First, a comment that Dr. Guzman is told. The great problem in these situations, and if you have some pericardial tamponade, is not pericardial fluid. You have pericardial fluid, you can use anything to study. But when you have tamponade, you can find the hole in the heart or in the vessels the vessels near the heart in the pericardium. So I think in this situation, you can extend your incision because anterolateral thoracotomy is very difficult to see the vessels on the right side. The injury is on the right side. So it's very, very difficult to see it. So you can missing injuries in this situation. And then you can be problem around. You can see the patient may become stable after the surgery. So if you put a drain, you can maybe see that continue the pericardial blending, and you can review the pericardium. So it's very important sometimes. And the second, when you can see these injuries, can suspect the injuries of the vessels near the vessels in the pericardium, like pulmonary artery or other, you can use some arteriography to see it, because the CT is not very clear to see this in this situation. So I think if you have problem, you have to go to make a arteriography to see it. But I agree with all. This need a cardiac surgeon, because in these situations is no one hole, maybe a pseudoaneurysm of some arteries or some injuries that you can fix it using extracorporeal techniques to fix it easy, if no problem. You can try to do in anywhere, can open again and try to fix it. But I think it's more safe for the patients to go to a cardiac surgery with have some extracorporeal shunt.
Perfect. All right, great comments. Dr. Farooqi, I think you can move on in the interest of time.
So we asked cardiothoracic, we asked them for the consult. They wanted us to start anticoagulation for the PE. It was a heparin drip. They took him to the OR later that day, got a median sternotomy, found tense pericardium with a large amount of blood clot. They found 2 non-bleeding lacerations, and one of them was on the right atrium, around 5 millimeter, and the other was on the more inferior towards a diaphragmatic surface. It measured around 1 centimeter. Both were repaired with flegited fluoroproline sutures. The patient, it's not, okay, I don't know what's happening. After this, the patient did well. He was, there's something wrong with mine. It's okay. Some technical issue. So the patient did well after this, and then he was discharged. He was transferred to ICU again, did well, and he was discharged home in 3 to 4 days.
All right, so basically there was like small lacerations, cardiac lacerations that probably bled out a little bit, oozed, and there was a big clot.
Yeah, and it was all on the right side. So, you know, the points, all these points that are valid, that if you're suspecting it, the blood has come from somewhere, you know, extend the incision, look on the other side. The other thing that we talked about was there any utility to get a transthoracic echo? If we did not, say if we were thinking about, we shouldn't be, you know, this is 18-year-old kid, we found where the bleeding is, not that, you know, we couldn't really find anything. So rather than giving him a more invasive incision, should we have gotten a transthoracic, rather than transthoracic, a transesophageal, seen if there was an injury, and then, you know, decided appropriately. So I think that should have been one of the considerations. We did get a post-op echo, but you know, transthoracic cannot catch these things. The other thing is, I think in my opinion, the field of surgery and trauma is very different from how it was, say, 20, 30 years ago. It has become more subspecialized. So we should have involved cardiac surgery. At least we are a level 1 trauma center, so we do have the subspecialty. So I think we should have involved them sooner than later in care of this patient, because it's at the end of the day, it was a case of the missing laceration, right? You cannot just have the 10 centi, the peri, the fluid from around the liver cannot just like migrate up. It's anti-gravity.
Yeah. Well,
Yeah.
Dr. Farooqi, I mean, the best cases in these meetings are the ones that we can spot something that we learn from, right? I love to also when I bring my cases, I always try to bring cases that something went wrong, because that's when we can discuss this a little further and learn about it. So I think it was a great case, very interesting, and with a lot of learning points here. And I think that the panelists as well, their inputs were fantastic. So let me go for a round here with the panelists again and make sure that they can provide any final comments. Dr. Untracht.
Yeah, great case. And you know, in the end, really, you didn't do anything more than you would have done had you made the decisions differently. He's got the same scars, whatever. It's a second trip to the OR, second intubation, and all whatever. But I think there's a couple of good points. You know, despite the bias against xiphoid aspiration, you know, it's a good temporizing measure if somebody gets hypotensive and you just need a couple of minutes. However, the one time that ER thoracotomy has the highest success rate is this, where the patient comes in with vital signs and then loses vital signs right in front of you. That's the one time where it really makes a difference. So in that case, you know, you shouldn't do anything differently than what you did, the thoracotomy. And then, you know, the learning point is if somebody has a cardiac arrest from pericardial effusion right in front of you in the ER, you always need to explore the heart when you go to the OR. And in that case, I might have done it at the end of your laparotomy after the packing, but I think that's the lesson. And you know, any one of us could have made this mistake. It's different. You had to be there. Why? Maybe you can give some thoughts about why the team decided to skip that part. That would be the one interesting. You know, what was it? It's probably something about the situation. They just, you know,
I
lost.
was satisfied with the exam from the left thoracoabdominal, from the left anterolateral thoracotomy. They said we have looked into it. There's no more bleeding. Probably, you know, there was hemothorax and all these things. So again, you know, we actually had this discussion like it's not possible that, you know, it's an upward knife injury. Definitely, like, you know, it went from the liver all the way up. So we should always, if we don't see what we are looking for, then, you know, we look harder. And how can we look harder? We can call someone who's subspecialized in it. We can extend the incision, or we can get help from certain diagnostic modalities, which can also facilitate intraoperatively. Get cardiac anesthesiologist involved, have them get the TEE, see if there's anything suspicious on it. If you're taking the patient back, you know, have a look at it again. Get a cardiothoracic, you know, something like that.
Yeah.
So you know, the thing is, at that point, maybe they were focused on the injuries that this is a polytrauma case. So I guess when we did discuss it, like, oh yeah, but he's doing fine now. He did fine until like day 12 when he had a syncopal episode. The other thing we were talking amongst ourselves was, you know, utility of chest x-ray and what exactly, because when we went back and looked at the chest x-rays, they were also not giving us that much, like, you know, the increase in heart, it was very subtle until like post-op day 10, 12, when you know, they were like, oh, this is actually increased. Should we have just proactively, like, you know, gotten another imaging done?
Mm-hmm.
Yeah.
Yes. And also, I suppose you anticoagulated him afterwards when he on discharge, right? And then the other option is, how about just putting a thoracoscope up in the pericardium? Is that something anyone has ever done, just to examine? No, you don't do that. Okay, Dr. Hockman's shaking his head. You would do a sternotomy. Okay.
Perfect. Dr. Collet, any final comments on the case?
You know, It's a great case. It's sometimes very difficult to find all the injuries in the first time, but sometimes we need to make suspension. And then when we have to do a emergent thoracotomy, you can remember that the injuries on the right side, you can prolong to the right side to the left anterior thoracotomy to try to find all the injuries. But it's very, very, very difficult sometimes to see it. Today, you have ultrasound that you can find easily to see a pericardial tamponade, pericardial fluid, and then you can decide. Sometimes later, some years later, you don't have it. If the patient rests, you can go to an emergency room thoracotomy and then try to resuscitate the patient. But today you have some more exams can facilitate the treatment. Congratulations for the case. It's very, very interesting case.
Dr. Hoffman, any final inputs?
No, I agree. It was a very nice case. You shouldn't have given us the clue at the beginning, so it would have made it more interesting. But
Yeah, after
how
I
much
sent
we
it,
have, how much we
I
all have.
realized that. I was like, oh my God, after I sent it, I just gave it away. I should have just like
Give the trick away. So, but a few things. One thing I disagree is that cardiac surgery should not be involved at the beginning, and this is my bias. I think this is the purview of a trauma surgeon. The mindset to do these emergencies is very different of the mindset of a cardiac surgeon who tend to do all elective cases and they tend to do everything the same way. So in my experience here, we don't even call any, we call they will not come for something like this. But the mindset is very different. I have cases where they say, oh no, just put a drain and come out because they will do in a car. It's very, very different, the mindset. The incisions are different. So I think this is the purview of a, but this is my bias. Okay, this is not saying anything wrong. This is my bias. I am very lucky that when I have a case like this where I'm working, I usually get cardiac anesthesia because we have an excellent cardiac anesthesia department, and they will do a TE automatically. It will be very difficult, if not impossible, to see an injury like this on a TE. The TE will not help. If it's big enough to be seen on the TE, is big enough to really give you very, very serious problems. It's helpful when you have intracardiac injuries. Sometimes it happens. Then the stab wound have caught one of the chordae from one of the valve and create acute valvular insufficiency or a ventricular septal defect or something like that. But otherwise, the main use of this is to determine if there is tamponade or not, and see the motility of the heart, and if it's a coronary injury, if it's any dysmotility of the heart. So it's very useful to have them there. But the cardiac anesthesia, I doubt that we have been able to give you the injury in this case. The fact that this patient now has an anterolateral thoracotomy and a median sternotomy is a problem. So in a case like this, it's better to continue with an with a clamshell incision, because the chance of having the vascularized sternum on the left is much higher. And we have this discussion. Again, if something could have been done wrong, I'm not criticizing you because I probably did it not more once, but many times. So I have seen this happening where you have an anterolateral thoracotomy and cardiac surgery comes in and does a median sternotomy. And after that, you have the area to the left side is the vascularized, particularly the sternum, and that's a problem. So in a case like this, it's better to do a clamshell incision. If you have thoracic surgery, you can call them, because if they do heart lung transplant, that's the incision that they use and they feel comfortable. But the cardiac surgeons, the only incision that they normally use is the median sternotomy, and that's what they will do. And that can become a problem in a case like this. Or you can have the case that they will say, oh, nothing is bleeding, come out, and it shouldn't come out. You should look for the hole. But that's my bias.
All right. Dr. Kassim, what about you, sir? The final comments on the case.
In in my 40 years of surgical career, I can recall every bad case that I have done, but I can't recall any good things. All the good things gone And sometimes I wake up with nightmare with all the bad things that I have done. You always learn from mistakes other people make. Halstead said, learn surgery from other people's mistake and try not to make your own. And it's very brave of you and awfully generous of you, Dr. Farooqi, to show this case to us because we learned so much today from you. Thank you so much. Yes, it was not the prettiest case that you have shown us today, but eventually you saved the patient's life, and that's what matters the most. Thank you so much. I really enjoyed the case.
Awesome. So just a quick final comment from Dr. Taveras on the chat. He said some had advocated for no repair of non-bleeding cardiac injuries, and this case highlights why maybe we should repair them all if found, even if the decision of not repairing the injury in this case was made by not finding it. So there are some people that advocate this as well, and maybe this is one of the cases that it wouldn't go like nicely if we had found the injuries and we did nothing to repair it. So we are almost at 1 hour of meeting. I want to thank you very much, all of you, for being present today. We had a full room here today for Dr. Farooqi. Thank you very much for bringing this case. It was fantastic. And for Dr. Untrak, Dr. Taveras, Dr. Collet, Dr. Kasim, and Dr. Hochman, thank you very much for your comments. You guys have been awesome panelists as always. So thank you very much for being present, and I hope to see you all again next week. Dr. Hochman asked about the CME credits. We are fixing this with Kevin and the people from UM as well.
Yeah.
You will be Kevin. Do you have any inputs?
From what I understand now, maybe it's a new UM policy for CME credit, but I need the presenter's slide deck in addition to the flyer to submit. So Dr. Farooqi, if you can email me that, I would appreciate it. So yeah, thank you. So this is my first time submitting or doing the CME process, everyone. So just bear with me and I'll figure it out and I'll get the code out or whatever needs to be done to make sure people get
available for every presentation that we do, because I don't know what happened if he had CME for the last one.
Last week's you're talking about? Yeah, that's the other. Yeah, I'm still trying to work on that to get the credit from last week as well. Yes.
All right. Okay. Sounds good. Thank
you. Thanks. All right.
All right, everyone. Thank you very much. I hope to see you all next week.
Dr. Menegoso, your cat looks hungry. Time to feed the cat.
I have two here, so
there you go. Both of them. At least.
All right. Thank you. Bye-bye.